The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and good evening. I'd like to welcome back any new participants, as well as welcome back any previously participating people joining us tonight. And before I introduce myself, I'd like to bring your attention to the poll that should be displayed on the screen in front of you. If you could please click on the response that best applies to you. The question is, in what profession or role do you represent? And it's my pleasure to welcome you all to tonight's interprofessional virtual Grand Rounds presentation by the American Academy of Developmental Medicine and Dentistry. My name is Michael Tarr, and I'm a third-year medical student, actually now fourth year, from New York Medical College, and I am the AADMD virtual Grand Rounds facilitator. So I'm going to close this poll and share the results with everyone. So tonight we have joining us 14% of the participants are working in administration, 4% are students, 32% are joining us from medicine, 4% are from dentistry, and 46% said other. So I'm just going to bring up the next poll. And the next question asks, in which stage of your career are you in? And you can answer that just while I continue to talk. So the AADMD Virtual Grand Round sessions seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, future healthcare providers in training. And the purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any questions you have for the presenters. Questions can be submitted through the Questions tab on your gray control panel on your screen. So I'm going to bring up the results to that poll. So we have 4% are pre-health profession training, 9% are health professional training, 4% are in residency, 74% are currently practicing, and 9% are retired from practice. Yeah, I should have one more poll, and that should be on your screen now. So tonight's presenter is Dr. Steve Sulkus, and Dr. Sulkus is a professor of pediatrics at Golisano Children's Hospital in Rochester, New York. He is leadership education. He leads leadership education, neurodevelopmental and related disabilities project director and pediatric discipline coordinator. He's a co-director of the Strong Center for Developmental Disabilities, Rochester's UCEDD as well. He is board certified in developmental and behavioral pediatrics and neurodevelopmental disabilities. He is a fellow of the American Academy of Pediatrics and of the Society for Developmental Behavioral Pediatrics. He is currently also the president-elect and now I believe sitting president of the American Academy of Developmental Medicine and Dentistry. And he has been treasurer of the AUCD and board member of Society for Developmental Pediatrics. So let's review that poll. All right, so joining us, we had 33%. Oh, I might not have had it open long enough. Looks like not many people voted, but of those who voted, we have 33% said they're looking to gain interprofessional perspectives, and 67% said they're looking to gain pearls from complex and challenging clinical cases. Okay, and with that, I'm going to hand the floor over to Dr. Sulkus. As I hide this. All right. The poll should be good now. All right, off to you, Dr. Sulkus.
Okay, well, I'm going to begin by saying that, at least from my end, a lot of that introduction, the audio was bouncing around and was not very consistent. So if you're having trouble hearing me consistently, please send a message so that we can fix that technical glitch. Maybe I should just wait a second so that we can hear if the audio is working for everyone.
Might have been my reception, Dr. Salkis.
Okay.
Also,
assuming that everyone can hear me all right, welcome this evening. I'm happy to be here. I am Steve Salkis, and okay. Okay, and you broke up again. Anyway, so tonight's discussion is one that is a continuation of a discussion that we had at the AADMD meeting in Houston last month, and I hope that I can engage you and get you thinking about some of the ethical challenges that we are wrestling with. I'm going to begin with a quote from Dr. Atul Gawande. If you are not familiar with Dr. Gawande, you should be. He is one of the preeminent writers about healthcare in our country right now. His writing is phenomenally clear and very easy to read. He writes for the New Yorker, and he has published his stuff in several books now. And this is a quote from his book called Being Mortal. Okay. The quote is, "Death is the enemy, but the enemy has superior forces. Eventually, it wins. And in a war that you cannot win, you don't want a general who fights to the point of total annihilation. You don't want Custer. You want Robert E. Lee, someone who knows how to fight for territory that can be won and how to surrender it when it can't. Someone who understands that the damage is greatest if all you do is battle to the bitter end." So the point of this is that we all die. Everybody dies. And people with intellectual and developmental disabilities all die, much as we would like to have people get the best care we can get them, and that's what we as an organization, AADMD, are all about. We also have to recognize that death comes to all of us. And tonight's discussion is going to talk about some of the experiences we've had here in Rochester, New York, and think about some strategies that you can use if you are in the position of having to work with families and individuals around end-of-life decision-making. I'll go to the next slide. Can we go? There we go. I want to acknowledge the folks from the New York State Mental Hygiene Legal Services Office. For some of the slides that I'm sharing tonight. We'll talk about them a little bit more later. I also want to acknowledge a colleague here in Rochester, Dr. Kelly Yost, who's a psychologist who worked with me, whose experience is also reflected in some of what I'm sharing. Next slide. So let's just begin with the case. And since we're not going to have the opportunity here during this talk to have interchange, I'm just going to present it and let you think about it for a moment. But I'm going to have several of these what would you do cases. This one is about a 10-year-old boy who has average intelligence, so this is not a kid with intellectual and developmental disability, who's living with his parents and who gets injured critically in a motor vehicle accident. His hematocrit is 15, which is really low, and he's heading to the operating room. The parents are happy to have him have the surgery, but they're refusing transfusion because they're Jehovah's Witnesses. So without the transfusion, he could die. If you work in pediatrics, odds are you've encountered a case like this. And I can tell you that I even heard this specific situation referred to this morning on NPR in a story about Charlie Gard, who's the child in England with a degenerative mitochondrial disease whose family is arguing for active interventions. This is a situation where the family is arguing against an intervention that could result in the child's death. And as I said, if you worked in pediatrics, what you know is that a situation like this, healthcare providers will go to court to override the wishes of the parents in defense of the child's life. Happens all the time. Next slide. Now let's take a child who has an 18-month-old who has trisomy 18, has profound intellectual disability, but whose cardiac status is stable and has respiratory syncytial virus pneumonia. It has been traditional that healthcare providers will say to the family, the life expectancy of a child with trisomy 18 is very, very brief, and we can help make this child comfortable, but this pneumonia, if you chose not to treat it, would be probably fatal and would be an honorable end to this child's life. Some families would go for that, some wouldn't. And if you read the textbooks on trisomy 18, people would say that treating this pneumonia is futile because this kid is going to die within the next year. But I can tell you that I have a patient here in Rochester who is over 30 years old and has trisomy 18, and she has been sick many, many times and continues to function at her admittedly very low baseline, but she's at her baseline and she carries on. So this one's a little trickier. No one would go to court to tell the parents to treat or not to treat, probably. They would leave it in the hands of the parents. Next slide. In the world of developmental disabilities, we talk about prevention. And I just want to get these notions out there for you, because what we're about in our world is preventing things preventing bad things from happening. So primary prevention involves keeping something bad from happening. And the classic example in the world of developmental disabilities for primary prevention would be immunization to prevent Haemophilus influenza meningitis, which resulted in severe developmental disabilities. So you immunize the child against that. Child never gets the meningitis, and you prevented the bad thing from ever happening. We'll come back to that in a second. Secondary prevention stops the bad thing from happening, even though it's already started. And the classic example for that, I hear you all saying with one voice, is PKU screening. Phenylketonuria is an inborn error of amino acid metabolism. It can be identified in a newborn with a heel stick blood test, and if identified early, the child can be put on a low phenylalanine diet and have no developmental disability at all. The third level of prevention, tertiary prevention, is helping the person who already has a developmental disability situation in place to make the best of his or her life. And most of what we're about in the world of AADMD is tertiary prevention. We are in the world of helping people who have intellectual and developmental disabilities be as healthy and as functional and as included as they can be. So let's take those and go back and think about healthcare ethiks. And if any of you have taken classes in medical ethics, the two or three dominant notions are, number one, beneficence, which means doing good, or its converse, non-maleficence. And if I had a picture of Maleficent from Sleeping Beauty, I'd put it up here, but I don't. But so first, do no harm. That's non-maleficence. Okay, so doing no harm. And then the second principle is autonomy, which is having the individual make choices for him or herself and not getting in the way of those choices. The third principle is one of justice. And justice takes two forms. One is equivalence of opportunity. So if one person has the opportunity to get something, then it would be unjust to keep it from someone else. Okay. The flip side of justice is distributive justice, in which we argue that, or a person might argue that we don't have enough resources to go around, and we have to figure out how to do the best for the most people with limited resources. Back to our prevention ethical challenges for a second. In the world of developmental disabilities, primary prevention, even though it seems pretty straightforward, we say we are going to prevent the developmental disability condition from ever occurring in a person, sends a message to people who have that condition that it's an undesirable thing to have. And many disability advocates will argue that their disability condition even though they don't want to be defined by it, they define themselves based on it, and it's part of what gives them their identity. So to devalue their identity by saying it should be something prevented is an insult to them. Okay. The notion of secondary prevention is one of imposing a treatment on a person when they might not want it. And again, restricted diet for a kid with PKU seems pretty straightforward, but you could imagine perhaps situations where a secondary prevention is going to impede someone's life in a way that they just don't want to be bothered. Say, for example, a person with spina bifida who needs a shunt, and they say, I don't want a shunt. That's a secondary form of prevention that the person might refuse. And it would be autonomy versus beneficence. And the third one, tertiary prevention, which is probably the thing most relevant for us tonight, is treatment to help keep a person alive, keep a person functional. And some people would say, I don't want these treatments. Don't bother me with them. I hate them. And that is autonomy versus beneficence. And you see how these things play off against each other. You probably have figured out from the title and from what I've said so far, we're probably not going to have any firm answers to all these questions tonight. And if you have to drop off early, I'll give you the punchline that every case is an individual one, and that generalized probably are not a good idea. But we'll keep going. Next slide. So as I said, folate supplementation to prevent neural tube defects and immunizations are things that are involved in primary prevention, and these are things that we have people refusing sometimes. And we have to say, is it a person's right to refuse things, even though they may prevent the person from having problems down the road? Next slide. The secondary prevention example was diet in PKU and diet in autism. We have people in autism spectrum who have autism spectrum disorders who are super picky eaters, and we want them to eat better quality food, and they refuse. Is that their right? Sure. Is it good for them? Probably not. Okay, next slide. Tertiary prevention. A simple example for those of you who work in physical disabilities is wearing orthotic devices. It may make a person ambulate much better, but they hate the idea of wearing orthotics, and so they refuse. Early intervention. Some people would argue that developmental early intervention, it ought to be very straightforward. It should be acceptable to everybody. But some families would say, we don't want strangers coming into our house to work on our kid, or we don't want people coming in and telling us what to do with our kids. They prefer autonomy. And then finally, we come to end-of-life care, which is the main topic for tonight. Next slide. When we're doing medical ethics, it's important for us to start, and I'm going to say this probably 20 times during this talk, we need to start from good medicine. So we can't just take a basic statement and assume that that describes the whole situation. We might discover that we are, in fact, ignoring important medical facts. So we need to get all the facts on the table, and we need to think about the advantages of an intervention and the risks that it carries. There is no treatment that anybody does in healthcare that doesn't have both benefits and downsides. No treatment at all. Physical therapy seems to be all plus. Not necessarily. It takes a kid out of the classroom. It may cause discomfort in range of motion. You get the idea. We need to be aware of historical perspective. And there is a long history of discrimination against people with developmental disabilities. And so we need to be cognizant of that and be aware that people who have been discriminated against, is this a message to me that I have a slow connection? I don't know. Anyway, sorry, I just got a message on my screen. Historical perspective, think about Willowbrook. Think about what the Nazis did to people with developmental disabilities, and realize that limiting care, limiting treatment could be could be something that's front of the mind for the person on the other side of the table from you. Each of us, in whatever discipline we work, has a professional code of ethics, whether it's a Hippocratic oath or the Oath of Maimonides or some other code of ethics that we work in, and we need to recognize that we've probably signed on to some code in the process of coming into the field that we're working in. There are pros and cons for the individual and his or her family and for the community, and we need to get them all out on the table so people can be making decisions. The community's involvement in an individual's life is a little bit tricky, because how big do we count as a community? But we need to look at the environment, the setting in which the patient in front of us lives, look at the circle of support. And that finally brings us to whose decision should it be? Whenever possible, it should be the decision of the individual, him or herself. But sometimes individuals with developmental disabilities can't tell us what their preferences are. We'll come to that later. And then who should it be? I think people are probably familiar with the Terry Schiavo case, where there was a big argument between Terry Schiavo's husband and her parents as to how to proceed, and that became national news in terms of one side opting for limiting care, the other side opting for more aggressive intervention. Next slide. Okay. If we had an opportunity for back and forth at this point, I would ask members of the audience to share what their codes of ethics talk about in this. I think we'll just keep going to the next slide because we don't have time right now for discussion. In the past, there have been, and this is I'm sorry, there was another slide in front of this, but when we talk about medicalization of healthcare and a medical model versus a human rights model, okay, this actually came from another presentation about a little girl named Ashley X, whose parents wanted to do an intervention that would keep her small, and they ended up doing some rather aggressive interventions. We can come back to that case. The flip side is the UN Convention on the Rights of Persons with Disabilities, which unfortunately the United States has refused to sign on to. But as you see, every person with a disability has a right to respect for his or her physical and mental integrity on an equal basis with others. Next slide. Okay, we are at risk for being paternalistic or maternalistic, and that's something that we could fall into, but so can other people. And we'll come to that in a bit when we talk about the role of state governments and other governmental entities. Okay, the question sometimes comes up about the appropriateness of the surrogate. I've got a story about that later if you want it, but sometimes surrogates, at least legal surrogates, have abdicated their legitimate right to be surrogates by their behavior. It's easy in the healthcare world, or for people who are unfamiliar with individuals with developmental disabilities, to make assumptions about the quality of life of the person with developmental disability, purely based on the existence of the developmental disability, and that's something that I think most people listening to this presentation will recognize as an invalid notion. Sometimes family members will disagree with each other, like the Terry Shivo case that I mentioned. People will talk about the different versions of justice that I talked about earlier. They all talk about the need that we have to allocate precious resources. There is a traditional distrust of the healthcare system by advocates for people with developmental disabilities, based on how we in the healthcare system behaved in generations past. And some of that historical distrust lingers, and sometimes our less sensitive colleagues perpetuate good reasons for that distrust. Let's go on. Next slide. So, in making healthcare decisions, let's assume that every person has the right to make his or her own treatment decisions and the right to accept or decline life-sustaining treatment. That statement presumes capacity, presumes the ability to make those decisions. Okay, so everybody should have that right, but we can imagine individuals who might not have the capacity. Let's go on. Next slide. Karen Quinlan was a national case back in the 70s. She had a condition that required mechanical ventilation. Her father wanted to withdraw it, and a New Jersey court held that the right to privacy, which could be exercised by a surrogate, said that the father's wish could be honored. Next slide. In New York, close to Rochester, was a very important case called Storer and Eichner, and I'll just share the story with you. John Storer had profound intellectual disability, lived in a state institution, Newark Developmental Center. His mother was a legal guardian and was actively involved in him, in his care and his life. He had persistent blood loss through his bladder, required frequent transfusions, and the New York State Developmental Disability System, OPWDD, wanted to continue the transfusion, and his mother wanted to stop. They went to court, and a local court supported the mother. Next slide. This went to the Court of Appeals, and the decision said that a patient's common law right to determine the course of his own medical treatment is paramount to the doctor's obligation to provide the needed medical care. So a person's right to determine his own course should guide the doctor's behavior. Okay, and they said clear and convincing proof is needed in cases where it's claimed that a person now incompetent left instructions to terminate life-sustaining procedures when there's no hope of recovery. So if a person has lost capacity, but has, as I hope everyone on this call has, created an advance directive for him or herself. If you're competent when you sign that advance directive, it should apply. Next slide. Okay. However, an individual who was never competent at any time in his life, a person with intellectual disability from childhood on, in the eyes of the court was considered still a child. And a parent may not deprive a child of life-saving treatment, however well-intentioned. So this is basically the Jehovah's Witness transfusion argument. A kid is presumed to be not competent, and that a parent should not be allowed to withhold life-sustaining treatment, however good the intentions. Okay, and so then the final line was, neither the common law nor existing state statutes require people to seek prior court approval in cases involving discontinuing life-sustaining treatment for people who are incompetent. So they said life-sustaining treatment trumps everything else in this situation. Next slide. Who's the responsible decision maker? Well, the state in this case said people with developmental disabilities were subject to abuse and their lives were not valued by society. That's sort of the historical argument. Okay. Families could have competing interests from the individual. That's what the state said. You know, the family may want to get rid of this individual because he or she is hard to care for and they want him out of their life. And therefore, the state should protect people with intellectual and developmental disabilities. The family's case would argue that if the court identified a person as a legal guardian, that means that person should be able to make decisions in the individual's behalf. And that gives that surrogate a weighty responsibility to think about the risks and benefits and act as that individual would have wanted. And by comparison, the state is impersonal. The state is a state. They're not in the business of thinking about individuals. They're thinking about the public. Next slide. New York State then passed a law that says that surrogates can make medical decisions, including end-of-life decisions, if wishes were not known, but they established a process for making these decisions, and to do this, they had to define what life-sustaining treatment was, and that's at the bottom of the slide. Medical treatment, including CPR, artificial ventilation, nutrition, hydration. Okay, anything without which the person will die counts, and die within a relatively short time period, counts as life-sustaining. Next slide. So what counts as life-sustaining? CPR, intubation, mechanical ventilation, dialysis, parenteral nutrition, transfusion. What's not so clear? Gastrostomy, tracheostomy, bowel obstruction surgery, urologic surgery. These things might be life-sustaining, might not be, and we'll come back to that later too with some of the cases that I've got to discuss. Next slide. So who can be a decision maker? Well, a court-appointed legal guardian, a spouse, an actively involved child, an actively involved adult, an actively involved parent, okay, an adult sibling, an adult family member, and in this case, actively involved means significant ongoing involvement in the person's life, sufficient to have enough knowledge about the person's needs and about the person's day-to-day existence. Next. Surrogates are people who can advocate, and this would include anybody identified as a healthcare proxy, should be advocating for treatment and basing their decisions on beneficence and non-maleficence, on what the person's best interest, wishes, and beliefs would be. And best interests can be included to think about the dignity and uniqueness of the person, things that are going to preserve or restore health, relieve suffering, and consider the entire medical condition. In the law, artificial nutrition and hydration actually are considered to be a special case, because some people might want to get nourished and others might not. If giving hydration was potentially life-sustaining versus life-threatening. We can come back to that later too. Next. In New York State, we have this very interesting process that says that when life-sustaining treatment is being considered for being withheld, then two things need to happen: a capacity determination and a commentary on the impact of the life-sustaining treatment being withheld. So determining capacity can be done by a licensed psychologist, an approved physician, and that means someone who is currently working for New York State Developmental Disability System, previously worked for them, or has been approved by them. In my hospital at the moment, there are two of us who previously worked for New York State, and we get called all the time to do these capacity determinations. So I'll show you some numbers a little bit later. Okay, it's me and a psychologist. We are trying to get some of our other colleagues approved. We're working on it. Next slide. Okay, the attending physician needs to determine whether the person has a terminal condition, or if the person is permanently unconscious, or if the condition that requires life-sustaining treatment is irreversible and is going to continue. So at least one of those, and that the proposed treatment is going to impose a burden on the patient. So it's not just enough to say that the person is going to has a terminal condition, but that CPR is going to impose a burden, for example. Next. What constitutes an extraordinary burden? Well, you need to take into consideration the person's overall medical condition and the outcome of the treatment. And you can only withhold artificial nutrition or hydration when it poses an extraordinary burden. I'll give you an example of that later. Or when there is no reasonable hope of maintaining life. Next. In New York State, we have to notify the state 48 hours before withdrawing, or as soon as possible if withholding. We have to inform the family, the patient, the CEO of our medical facility, our hospital, the mental hygiene legal service people, the attorneys if the person lives in a group home, okay, and the commissioner of OPWDD if the person lives at home with their family. So we have to let these people know. And what's going to happen is that, go ahead, next slide. There is the potential for people to object to this withholding. So who could object? The patient could object, the parent could object, an adult sibling, family member, healthcare providers, the director of the facility, mental hygiene legal services, or people from OPWDD. And they have taken the position in my community of having a default position of objection until they say they've decided they're not objecting. That effectively puts a hold on any restriction of life-sustaining treatment. You have to keep going. You have to keep doing CPR, ventilating the person, et cetera, until OPWD says it doesn't object. The reason they've done that is because they want to be sure that people are not withholding treatment from people with intellectual developmental disabilities for bad reasons. Next slide. In the past year, my colleague and I did 23 consults. The average age of the people that we consulted on was about 42. About 40% of them are still alive, even though it's been months since we did their capacity evaluations. One was alive at a year out, okay? And the average age of those still alive range from little kids to older adults. For those who did die, the average time from when the capacity evaluation happened until the person died was about 3 weeks. Okay, and the range was that day because support was withdrawn, or as much as 3.5 months out. And the age of death was a little bit older at 47, 48 years, but you see that the range is, we had an 87-year-old and we had a roughly 19-year-old. Next slide. So what I want to do next is suggest, and this is open for discussion because I'm eager to have your feedback in the Q&A time, a little algorithm for thinking this through. And the first question I ask is the medical condition for which treatment is being withheld related to the underlying disability condition? So, for example, if the person has spina bifida and needs a shunt redone, that would be because they have progressive hydrocephalus and they're going to die without a shunt. I'd say that's related to their underlying condition. Okay. If, on the other hand, the person has cancer and that cancer is unrelated to their medical condition, their underlying developmental disability condition, then I would, then we need to move on. Okay, but if it happens to be related, is it an anticipated natural history feature of the disability condition? So, is it something where the person's underlying disability condition is going to progress because all the evidence we have is that this kind of progression happens in this in this situation? And those of you who've been following the story of Charlie Gard in the news know that that's sort of the situation for him. He's got this mitochondrial disease, I believe, whose natural history is one of progressive neurologic disability and eventual loss of respiratory function and autonomic instability and death. Now, in that case, his family is pushing for an experimental treatment, and we can come back to his case later at the end, too. All right, the next big question is this medical condition reversible? And if it's reversible, at what burden to the individual or his or her family? Because if it's reversible, then we ought to try to reverse it. We shouldn't be withholding treatment for a reversible medical condition if the burden is acceptable. Okay, most people, for example, would accept chemotherapy, at least a first round of chemotherapy, for malignancy because they might hope that there would be a reversal of the malignancy. On the other hand, the chemotherapy medications might be so onerous that the person might say no because the burden was too high. So if the condition is not reversible or the burden is too high, then that's a time that it might be reasonable to limit treatment. Next slide. The next question has to do with capacity. And what I do is try to find out whether the person is verbal. And if the person isn't verbal, then how else might he or she communicate? Because in the world of healthcare, people often overlook the fact that patients can communicate in ways that are nonverbal and don't ask. Then the related question to that is whether this person has had a specific cognitive level previously documented. If the person is functioning in the mild range of intellectual disability, then you might expect them to have much more ability to participate in their decision than if they were tested repeatedly and shown to have severe or profound intellectual disability. If the person can communicate, then does he or she understand what the condition is? What is the thing that we're talking about treating or not treating? And then the second question is, what is the treatment that we're talking about doing? and what are the potential benefits, what's it supposed to be doing, and what downsides might this treatment have. And since we're talking about life-sustaining treatment, the implication of not treating is that the person will die. Well, if that's the case, does this person understand that that's going to happen and then have some kind of concept of death? And then the next question is, if that person can't communicate it now, has he or she done so in the past? And how do we know that? How do we know how they did that? Next slide. I want to, actually, let's back up for another second. Come back to the previous slide. Okay, let me share a vignette that I might come back, it might come up later, but it's a good example. And this was actually the first time I did this. I was asked to talk to a gentleman who was in his late 50s, whose previous tested IQ was in the mild to moderate range. He lived in a group home, and what I was told was that he had previously had a hematologic malignancy, leukemia, had had a course of chemotherapy, had gone into remission, but now he'd had recurrence of his leukemia, and he was refusing chemotherapy. And I was asked to come assess his capacity to refuse chemotherapy. So I went to his home, met him for the first time, sat in his room with him privately, and it turned out he was verbal. He was able to talk to me. And I said, "What's wrong with you?" He said, I said, "I hear you're sick." He said, "Yeah." I said, "What's wrong?" He said, "I've got cancer." I said, "Yeah, that's what I hear." I said, "It sounds like it's pretty bad." He said, "Yeah." I said, "They want to give you chemotherapy." And he said, "Yeah, I don't want it." "Why not?" I asked. And he said, "It makes me sick. I had it before and I didn't like it." I said, "Oh, well, yeah, and it often does make people sick. What would happen if you didn't get it?" He said, I would die." I said, "Yeah, I heard that too." And he said, I said, "What happens when you die? When a person dies? What happens when you die?" He said, "I'll go to heaven and see my brother." And I said to him, "Thank you, sir." And that was the end of my interaction with him, because to my mind, he knew what his condition was. He knew what the treatment could do for him. He knew what the burdens of it were. And he knew that if he didn't accept it, he was going to die. And he had a concept of what death meant. That was enough for me. And the fascinating end of the story, which I love, is that this was back in the early 90s when George Bush Sr. was running for president. And this guy wanted to meet him, and it turned out he made a campaign stop in Rochester, and there were pictures of this gentleman backstage with President Bush shaking his hand and getting to meet the president, which I thought was lovely. The second part was that after he died, I was called by the leadership of the agency where he lived, and they called me in to thank me. And I said, "Well, you don't need to thank me. I just did what you asked me to do." And they said, "Well, here's why we needed you to do it." Turns out that this guy was the last surviving member of his family, and there was a big pile of money, like $500,000 in trust in his name, that was going to go to the agency on his death. And they wanted to support his desire to not pursue chemotherapy, but they did not want to be viewed as hastening his death and possibly doing that to get the money. So they brought me in as an outsider to, without ever telling me that, to help me so that I could ascertain whether his wishes were really his wishes. So I thought this was an incredibly menschy thing for this agency to do, and I applauded their supporting this man in his wishes and recognizing that he had capacity. Now let's go on to the next slide. When I talk to people about child development, I talk about function versus age. And this is a simplistic graph with the upper line being typical development and the lower line being the slower development that you might see in a person who has Down syndrome or cerebral palsy. They're progressing all through their life, but they're progressing at a slower rate, falling further behind, but still making progress. And when I am defining intellectual disability for people, this is a graph that I use. Next slide. Now, if you take that graph and plot the slope of that graph, so instead of function, now versus function for age, as long as the person's progressing in a straight line, their line in this graph is going to be horizontal. But for every person, we change. Our function goes up and down. We may have something good happen and we have a step up in our function. We may have a transient downward blip. For those of you who are residents, it might be a night on call, but you can recover from it. It could be a broken leg. It could be some injury or some illness that you recover from, and you get back to your previous baseline. Then something else happens later on in your life, and now you have a step down from which you don't bounce back. But you're still on a baseline, and then another thing happens and your baseline drops further, and then so on until it becomes an inexorable downhill slide. This could be anybody's graph. It could be mine, it could be yours, it could be the graph of a person with a developmental disability, because it doesn't actually say what the person's function is. It just says, it just talks about the person's baseline. And I actually like this construct because what it says is that we all eventually come to a point where we get to that inexorable decline, and at that point it might be reasonable to think about limiting aggressive interventions. Next slide. In my 23 patients that I talked about earlier, we had some who actually did have capacity, and a couple were being recommended for surgery that people were viewing as life-sustaining, like having G-tubes and trachs put in that they and their caregivers didn't want them to have. And what this meant was that the state was forcing people, in essence, to have surgery over the patient's consent. And one of the things that I found myself doing was saying that the patient, in these cases, had capacity to refuse invasive surgery. But under the notion of life-sustaining, the implication was that people would actually have to have surgery without their consent or without their guardian's consent, because it was viewed as life-sustaining and therefore would trump other consent. I'm sorry about the political reference there. Anyway, I thought that was fascinating, but we do have some patients who say no to things. Next slide. Okay, so this is I'm just going to run through some cases, and we can talk about any that you like in the Q&A time, which is coming up fast. But how about a 3-year-old girl with severe congenital microcephaly, profound intellectual disability, difficult to manage seizures, severe reflux, and recurrent aspiration pneumonia? She already has a G-tube, but she's continuing to reflux despite all of our efforts. Should we stop feeding her? Could we stop feeding her? Next slide. A 7-year-old with progressive neuromuscular disease and normal intelligence who's having recurrent pneumonias. And in this case, the parents want everything done. This one's interesting because this is a kid who has normal intelligence and who might be able to communicate his or her own wishes. What if the kid says stop and the parents say keep going? Do children have capacity to say no? At what age? Next slide. This is a case I encountered, a 12-year-old with mild intellectual disability and hyperactivity who was on methylphenidate and who was found in a swimming pool and resuscitated on site, now has marked hypoxic ischemic encephalopathy. In this case, the parents, I'll tell you what happened in this case because it's fresh in my mind. They called me in to do the capacity thing. I already knew this kid because I was one of his treating doctors. I was the guy prescribing the methylphenidate. And the parents said to me, he suffered so much. And I said, hang on, what do you mean he suffered so much? And they said, well, he suffered so much. And I said, well, if you could get him back to where he was before he had this drowning episode, would you want to do that? The mother said, absolutely. I said, so you're not saying he suffered from having developmental disability. You're saying he suffered because of this horrible drowning thing, and that's why you want to limit the intervention. And they said, right. And I said, okay, that's a different story. You're not withholding care because of his developmental disability. You're withholding care because he now has irremediable hypoxic ischemic encephalopathy. Next case, next slide. 7-year-old boy with spastic quadriparesis, moderate intellectual disability, new seizures with apnea. And the parents say, don't treat. The doctors say, treat. Or vice versa. You could make it go either way. Next one. 16-year-old severe spastic quadriparesis, profound intellectual disability, born to a 13-year-old mother who's been uninvolved, raised in a family care home until recently, moved to a group home. Now he's in the ICU. DDSO is state-run family care. Now he's in the PICU on a ventilator. And this is a case I was actually involved with. Because of his severe cerebral palsy, spastic quadriparesis, he had restrictive lung disease. And it turned out that if they gave him enough calories to meet his needs, he couldn't blow off the CO2 that he generated from burning those calories without the help of a ventilator. On the other hand, if you stopped the ventilator, you had a choice of feeding him and keeping him on a ventilator, or stopping the ventilator and not giving him enough to eat. So it was a near insoluble problem. And the reason I mentioned the mother, this is a true story, is that there was an aggressive intensive care doctor who wanted to stop the ventilator. And this guy was 16, so he was still a minor. His mother hadn't been involved in his care since he was an infant. But the doctor tracked down the mother who was living in another state and said, here's the situation, can we stop the ventilator? And the mother said, sure. And in that case, the state said, whoa, hang on, this mother has not been involved in his care at all. How can she have any say in limiting life-sustaining treatment? On the other hand, the state said, keep him on the ventilator, but we're not going to take responsibility for caring for him. We just object to withholding it. So here were two people, two entities, one a person, one a state, both of whom were talking about which direction they wanted care to go, and neither one was going to take responsibility for the outcome. Next one, next slide. And that's it. So let's open it for questions. We can talk about any of those cases or anything else you guys want to talk about. How do we do this? Do I hear voices or do you present written questions?
So people can write in. I can also, we tried this last time to see if someone has their hand raised, I can try to unmute them. Now, everyone who's participating, they have to know that when you're unmuted, so everything's going. So I'll, if you have your hand raised, I'm going to assume you have a question. I'm going to unmute you and see if that works. All right, so Linda Leal. Let's see.
Not hearing anything.
No, I'm not either. Connected to, it says connected to audio. Other option is, in the interim, is the participants can write in questions just as they did in the beginning. And so our question box will light up. Let's see. Just trying.
I'm assuming people are still on.
Yes. Yep. Oh,
Okay.
Here we go. Okay. Received. So the most recent question is, would dementia in a person with Down syndrome be related to the underlying disability condition because of trisomy 21 connection?
That's a great question. I would say that it is related, but that sort of shifts the whole question into the person having dementia. And then it becomes, in my mind, almost the same question as any other older individual with dementia, and whether and when and how life-sustaining treatment should be provided. My personal feeling is that if a person can get back to his or her baseline, even if it's a slowly declining baseline, that is a reasonable option if the burden of treatment is not extraordinary. So I mean, but yeah. So your question is legitimate, because we know that dementia happens with people with Down syndrome, happens at earlier ages, and is for many people a part of the condition. Of course, we also know from, and I'm sure you've heard this in previous presentations in this setting, that there are many people with Down syndrome who are viewed as having dementia who actually have treatable conditions like depression, like hypothyroidism, like gluten enteropathy and malnutrition, and that people should not just assume that a cognitive decline in a person with Down syndrome is dementia. Could be obstructive sleep apnea, could be many things. So we need to be aware that there are conditions that are associated with Down syndrome and conditions that happen frequently in Down syndrome, but that dementia is not inevitable in all people with Down syndrome.
Great, thanks.
I don't know if that's a good answer, but it's a stab. But I know where you're coming from.
Right.
Another question?
Yeah. Do you have to determine capacity in all pediatric patients?
Isn't that wild? Okay, good pickup, whoever asked the question. Okay, in New York State, it turns out I do. And you would think, all pediatric patients who are served by the Developmental Disabilities Agency. So if a kid has never been served by the state, just has been served in school and never had state support, notifying the state is optional. And one of the first things we do is ask the family, are you getting any services from the state? Because if they're not, then the family, as would be the case in any other family, is the legal guardian of their child, and determining capacity is kind of moot. A related question is related to one of the cases I just posed, where a child who doesn't have intellectual disability has a terminal condition and has voiced opinions about life-sustaining treatment. We have to include the kid's input, I think, in decision making, if the kid seems to have some measure of capacity. Under the law, children don't have capacity, and they magically develop it at age 18. So it's a very stark line that's age related for people who do not have intellectual disability.
Right.
When I'm asked to do these capacity evaluations for kids with developmental disabilities, one of the lines in my templated note says, you know, even beyond the fact that this is a child who by law doesn't have capacity, this child doesn't have capacity because of the developmental disability. So, you know, it's kind of redundant, but I do talk about that, and you're right to pick up on that.
Thank you. Next question is, how would you suggest the interdisciplinary team address a discussion in which the physician refuses to consider hospice or palliative care unless the patient has stage 4 cancer and only has days to live?
I'm trying to. That's a very specific case, obviously, and I am trying to imagine why the provider is refusing to provide hospice care. There are various reasons why doctors do that. One is that they can't give up, and I refer you back to Atul Gawande's book on that. Sometimes they are fearful of litigation or recrimination from a state agency, and therefore don't want to be in a position of providing hospice care. Okay, and you didn't in the description. You mentioned that the person that only has days to live, but does the person have a DNR order? I mean, is the person going to be allowed to die one place or another? There are factors in that question that I guess I can't completely answer it because I don't know all the details. But I mean, but what I would say is, why is the person who has developmental disability, who has stage 4 cancer and days to live, any different from a person without developmental disability who has stage 4 cancer and only days to live? The treatment, the approach should be the same in that situation.
Do you see a difference between taking no action and taking action needed to sustain life? And the question asker wants you to know that they're calling from Canada.
Thank you for calling from Canada. That's great. I think I'm in Rochester, and I think I can hear you across the lake. Taking no action is a decision, and I think, so whether it is actively doing something, actively withdrawing something, or making a conscious choice not to do something, all of those are decisions. And I think in each case, the elements are sufficiently different that it needs to be considered based on benefit and burden. So taking no action could have benefit and it could have burden. Taking action could do the same thing, whether it's actively intervening or actively withdrawing. So from my perspective, I guess I would say that a decision is a decision, and it needs to be in context.
Mm-hmm. Thank you. So this is in relation to one of your cases, I believe. Oh, maybe not. If a person who does not have the capacity to make the decision has a guardian, can the guardian complete a DNR or an advance directive for that person which delineates what they wish to be done in certain situations, or must those decisions be made in real time?
It's way better to do it in advance. Okay, that's way better. However, there's a lot of state to state and perhaps country to country variation in the law in that regard. In New York State, that the fact that this was all done thoughtfully in advance wouldn't matter unless the individual, him or herself, had capacity when those decisions were laid down. In other states, that sort of thing can and should be done well in advance. So I would say way better to make the decisions well in advance, get them documented, and put them in place. But New York State has special legal rules that may not apply in other places.
Thank you. All right, I like this question. It says, what happens when a child wants treatment but the parents don't agree? Can you get ethics committee to assist?
Yes, you should. Ethics committees are great. However, as we've experienced in AADMD, sometimes ethics committees sometimes they agree with parents, sometimes they agree with kids. An ethics committee is going to go through similar kind of process to what we've talked about here and decide, how much capacity the kid has. I mean, and people look at cognitive level, verbal skills, complexity of the decision. I mean, so if you took a kid who had severe diabetes and the kid said, I don't care what my blood sugar does, I want candy, 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 and the parent said, you can't have candy, 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 it'll kill you, or the kid says, I want peanuts despite peanut allergy, the parent's decision would be viewed as superseding that of the kid, because on the other hand, there might be situations where a child would be very articulate and very able to share his or her thoughts, and then it becomes and then the situation becomes one of assent as opposed to consent.
All right, so it doesn't look like we have any more questions at this time, and I apologize to anyone who is looking forward to speaking. I'm going to look into having that fixed for next time and have that all set up. But also, Dr. Selkis, I want to let you know that we had several comments in the question box that commented on how they enjoyed your presentation, and I wanted to add to that and say thank you very much for taking your time and presenting for us and leading us in this fascinating and very important discussion.
Well, I will just finish by reiterating my main point, and I thank you for the opportunity to do this tonight, that we are in the business in AADMD of making sure that people with intellectual and developmental disabilities have access to the full range of healthcare interventions and options. That means, in my mind, both the access to treatment and access to dignified end-of-life care when that's appropriate for the person. And I think it is good for us to recognize that we can take those positions and advocate for people in all directions. That's why the title was from both sides, because I never assume anything in a given case. And I encourage you not to make assumptions either. Thank you all for joining us tonight. I appreciate it.
Yes, thank you. And before everyone or anyone leaves, I just want to remind you, if you didn't hear earlier, if you'd like to download tonight's presentation, the handout from it, you can do so through the handout tab on your toolbox. And if you'd like to share this presentation, the recording will be uploaded into the Virtual Grand Rounds library, which you can access through the AADMD website. And with that, I'd like to say good night.
Good night, everybody. Bye.
Bye-bye.